Okay, we're going to be looking at medical and diagnostic imaging as part of the chapter 3 part of CON. Now, a lot of what you're going to see here is not going to be found in this particular chapter, but it's a nice supplement and gives you a general idea as to what sort of imaging capacity we do have in the clinics or what we used to use. Most clinics are going to be beyond film at this point in order to position a patient. Not every one of them, but a lot of them will be. And so we're going to cover a little bit of film, but we're also going to move beyond that into other modalities and just touch on them to see what role they play in radiation therapy. So for conventional simulation, generally we're going to use an X-ray tube or fluoroscopy. There's some of that still in use, but a lot of that has really been replaced by CT simulation. You get a lot more information. It's much quicker. Is it more expensive? Sure. But the capacity that you have with CT simulation, being able to mark on a patient and send all of that information to dosimetry so that they can start planning, being able to take several images, not only that, but being able to gate, take a gating scan on somebody. These are the reasons why a lot of the older technology is being replaced. It's just the newer technology allows you so much more information. This information you will be able to find in chapter 3. Here's your image of an X-ray tube, or drawing, I should say. You have your cathode here, your anode over here. You have the glass envelope, the protective housing that will be going around that. A lot of this was covered in the previous lecture that I had over chapter 3, but you have a filament here which has a thoriated tungsten, which will help it to survive the very high temperatures you're going to need in order to be able to produce the thermionic cloud. You've got a cathode cup here, which helps to focus the electrons to want to be pointed towards the positive charge over here. Once those electrons are released and they strike the target, you will see the X-rays that are emitted here. A lot of the housing here is going to be lined with lead because you're going to have reactions that go, or photons that go all over the place. This is what you're interested in because this is what you're going to use to make your image. A lot of the production here is going to be lost to heat. 99% of the energy that comes through here is going to be lost to heat. You need a way to get rid of that. And the copper is what helps to bring that heat out. The tungsten target, it is used because you have a high Z number for tungsten, which allows more production for the type of X-rays that we're looking for. So you can see all of that we just covered. Tubes may have two filaments. One's a little longer than the other. The longer one, you're able to produce more electrons with it. The smaller one is used if you want finer detail for a specific part of human anatomy. You've got 0.6 to 2 millimeter focal spot size. Again, the focal spot size is what was addressed in the previous lecture. You can see here, the larger you have more electrons, smaller you have less. You've got the focusing cup. It's negatively charged in order to be able to force the electrons to move in the direction that we want. It also compresses the electron stream. The anode is going to be the positively charged electrode, receives the electrons. The anode is going to be composed of iridium alloyed tungsten. The line focus principle, so the actual focus spot size and the effective focal spot size, again, that's going to be addressed in the previous lecture. In other words, what you're actually shooting at and what is the effective are going to be a little different. So You've got your electrons coming in here, they're striking the target, and then you're seeing the rays being pointed out this way. It is angled here a little bit so that you can, I mean, if it were flat, you wouldn't be of much use because you're not able to get any useful rays out of that. You can see here that this size trigonometrically is A times the sine of the angle that is made. For diagnostic tubes, the angle here is about 6 to 17 degrees. And for a therapeutic, it's about 30 degrees. So you can see the central ray bouncing off here. You've got a larger effective focal spot here with this angle being larger. With a smaller angle, you've got a smaller effective focal spot, but the electron beams that are coming in here are the same. This would make sense because as this angle gets smaller and smaller, this side over here gets smaller. So 24 degrees, it's about this. When you cut the angle in half, you get a much smaller side. The heel effect we also discussed. What it is talking about here is that you have various depths in the target, or X-rays produced at various depths in the target vary in the amount of attenuation, with greater attenuation for those coming from the depth. So the intensity of the X-ray beam also decreases from the cathode to the anode direction. So in other words, you're seeing the intensity decrease as you go from here to here. You can minimize that by using compensating filters. So you've got a tungsten here. It's got a high atomic number. It's got a high melting point. It's used here for obviously the focal spot, and you can have it either rotating or be stationary. This is a stationary target. This is one that rotates. It consists of tungsten, molybdenum, and graphite. And if they had not put the picture here, you could actually see the cross section over here, but that is visible in the other video. Rotating targets have a bigger target area. They have greater heat dissipation, and they rotate fairly fast. So don't stick your finger in the way. So thick copper rod, almost looks like a lipstick tube in a sense. It's used in stationary targets. It houses the target, removes the heat, and because there's a lot of heat production with this, and it filters the inherent scatter. In other words, you're going to have scatter all with rays going all over the place, and so it helps to filter a lot of that. The glass envelope maintains a vacuum around the cathode and the anode, 20 to 30 centimeters in length, about 15 centimeters in diameter. The purpose of the housing is to control unwanted radiation leakage and electric shock. It's usually lead lined and decreases the amount of exposure to the patient as well as the operator. Prevents electric shock for the patient and operator, supports and protects the X-ray tube from damage, and it helps to cool the tube. And a lot of these are oil insulated. Now, how do you get a longer life? You're going to follow the warm-up procedure that is recommended by the manufacturer. You're going to have minimal rotation. You're also going to have lower MA exposures. In other words, don't keep this going until you're ready to shoot. So you have two different mechanisms of X-ray production. You have Bremsstrahlung, and you also have characteristic X-rays. So the characteristic X-rays are similar to other energies in the electromagnetic spectrum. Obviously, they travel at the speed of light. They have an undulating pattern, and they have short wavelengths. The thermionic emission is the electrons are going to be liberated in response to the heat, and they're called thermions. High-speed collision at anode produces the heat in the X-rays. Potential difference is going to be the voltage that is applied there. At peak, it is called kilovoltage peak. In other words, a maximum amount there. Forces the electrons from the cathode to the anode and determines kinetic energy of electrons and energy of photons. Target interaction, obviously you got a lot of heat, but you also have Bremsstrahlung radiation. So changes in the kinetic energy of electrons cause the X-ray emission. In other words, when the electron gets close to a nucleus, it changes direction. And with that change in direction, you're seeing an emission of energy. That's what's going on here. Speed up and slow down, 75 to 80% of the tube output. Characteristic radiation is when the electron goes in and interacts with the inner shell electron. Photon energy is approximately equivalent to the K-shell binding energy, and it speeds up and collides. The beam quality is going to be manipulated by the KVP, the kilovolt peak. It refers to the photon energy and affects penetrating ability of the beam. The quantity is going to be manipulated by the mass. It's directly proportional to the electrons liberated by thermionic emission. In other words, the more mass you have, the more of those electrons are going to be shot across from the cathode to the anode. The Bremsstrahlung is the interaction, well, there should be more to this diagram here, but there isn't. Electron suffers deflection and acceleration when it gets close to a nucleus. Means there's energy loss, and the direction of the loss is energy dependent. What this diagram here is showing is that the stronger the electron beam, the more forward that energy production is going to be. So the efficiency X-rays produced versus the input energy. It is related to not only the voltage, but also the square of the atomic number of the target. The efficiency is the product of these. The efficiency is X-ray energy dependent. So Bremsstrahlung energies, multiple factors that depict the energy. It's polyenergetic. 90% of Bremsstrahlung X-rays, you're looking at somewhere between 80 to 100 kVp, and there's a lot of heat produced. It is isotropic, meaning it is emitted in all different directions. It is divergent from the central point. They have short wavelength, high frequency, and cause fluorescence. If you've wondered what fluorescence means, it is the property of absorbing light of shorter wavelength and emitting light of longer wavelength. So in other words, it will it will emit things that will interact with other things that will emit photons of a longer wavelength. We have attenuation, which means a reduction in intensity through matter. The photons are scattered and absorbed, and varying degrees of attenuation determine image appearance. So basically, as your X-ray beam goes through some sort of object, the reactions are going to reduce the number of rays that you have going through, and that is the reduction of the intensity. Scattering is affected by the tissue thickness, the density, and the effective atomic number. So efficiency versus efficiency, you've got the transfer of electrons from outer shell and the transfer of electrons from the inner shell. Polyenergetic versus monoenergetic, you've got the shell transfer is going to be monoenergetic. In other words, in order for an electron to jump from shell to shell, there is a quantized amount of energy there. It's not going to be a spectrum. Multiple characteristic X-rays produced from one atom is going to be polyenergetic, because if you have several different interactions there, you could have several different jumps from one shell to the next, and that can produce different energies, even though those energies are in fact quantized. So the characteristic X-rays are produced from collision with orbiting electrons of targets and the freed electron produced during thermionic emission. So orbiting shells have specific orbitals associated with them, and they have certain binding energies. Obviously the inner shell is going to have the most, and then followed by the shell after that, and then the shell after that, and blah, 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 blah. So It is the threshold energy that an incident electron must possess in order to first strip an electron from the atom. In other words, this is sort of an ante, if you think of it in poker terms. You've got to have at least that much for this to happen, or it ain't going to happen at all. There's no bargaining on this. So you've got to have a certain amount of energy there in order to produce this reaction. As you can see, there's more energy. This is tungsten. This is the atomic number. This is the amount of energy it's going to be required in order to rip that electron out. For the L shell, which is a little further away from the nucleus, you can see that it takes a little less. And what you're also observing here is that the smaller the atomic number, obviously as you're going this way, it doesn't take anywhere near as much to get them out of the K shell. But you get up to something like lead or uranium that have very high atomic numbers, you better be packing your energy wallet here in order to be able to rip them out. So this is a tungsten atom. I know it doesn't really say that, but that's what this is supposed to be. If you have an electron jumping, say, from the L shell to the K shell to fill a vacancy, you basically take the energy difference between the two. You can see here's 12, and this is rounded to 70. So you're looking at 58 keV. Now that's one reaction that could happen if that stream of electrons comes through, interacts with this, and imparts enough energy to knock it out. It is more stable for the atom to be able to fill that vacancy with an outer shell, and then it can easily try to pick up something else in order to fill this shell. So as you jump from L to K, this is what's released. As the electron jumps from M to K, this is what's released. As it goes from M to L, this is what's released. So X-ray photons produced by the X-ray machine are heterogeneous in nature. In other words, it's a spectrum. The spectrum shows a continuous distribution of energy superimposed by discrete energies. As I had said, since we're looking at a combination of the two, the bremsstrahlung is not, that is a continuous spectrum. We don't know exactly what those energies to be released are going to be, and it just kind of depends on various factors. However, when it comes to the characteristic, we know that they have to jump from shell to shell, and we've measured those energies and we know what they are. So we know what that spectrum is going to look like. So it's going to be a mix of these two that you're going to see. So with no filtration, inherent or added, the calculated energy is going to be a straight line given by this. So I sub E is going to be the intensity of photons with energy E, Z is going to be the atomic number of the target, E sub M is going to be the maximum photon energy, and K is going to be the constant. So you can see those lines being drawn here. You got the relative intensity, which is what this is referring to. And then you've got the photon energies down here. So you put all that information in there and boom, this is what it would look like if it were completely unfiltered. But with the spectral distribution of X-rays for a tungsten target with no filtration, and then you add in about 1 millimeter of aluminum. And these are what you get. You can see the characteristic radiation here, which should fall between 50 and 100 keV because those are the electron energies released when they're jumping from shell to shell. But the rest of these are going to be produced by bremsstrahlung. So now we've got this polyenergetic beam. What in the heck do we do with it? We have the inherent filtration. So we've got the tube housing here. We've got the cathode over here. It's going over here, hitting the anode, the rotating anode, and then zoom, you got the X-rays coming out here. You've got a glass window, you've got a beryllium window, you've got the tube housing, and then you've got the target. You've got all of these things to try to focus where this radiation is going to come. Now, you've got this window coming out, or this set of X-rays coming out. How do you focus it once you've got this beam coming out? You've got these things called collimators here, where you can set these things to block the radiation going into an area that you just don't want it. And so you focus the X-ray beam even further. The beam hardening here that you get with the filtration. It enriches the beam. It absorbs the low energy X-rays and allows for better penetration. You don't want the low energy X-rays going all over the place. You don't want them going to the patient because it's not going to do you any good. All you're doing is increasing the risk of having something go bad, cancer develop or other things like that. You don't want that. You also don't want exposure to people operating the equipment. So that's why you're doing it. As you're filtering those out, you're also allowing this beam to become stronger and to be able to penetrate the patient to the degree that you're hoping for here. So the factors affecting the X-ray production, you've got the quality, which is the penetrability of an X-ray beam. You've got the quantity, basically the number of photons you got coming out. And then you got the efficiency, the ratio of the output energy as X-rays to input energy deposited by the electrons. In other words, the energy that you're putting in here to produce this, what's the ratio of this energy over what you're putting into it over here? Obviously, you'd like it to be more efficient than 1%, but depends on your setup. So all of these are characteristics that affect the characteristics of these X-rays. Now, interactions, you have different types of interactions. You're going to have photoelectric absorption. You're going to have unmodified or coherent scatter. And then you're going to have Compton scatter. So the coherent scattering is very little importance in diagnostic radiology. It occurs at less than 10 keV, and you don't really get a lot out of it. For the photoelectric effect, it's also known as true absorption. It occurs with the inner shell electrons. So you've got an electron that is shot over. It interacts with an electron in the inner shell. It absorbs a photon, and then that emitted electron, called the photoelectron, may undergo reaction in the tissue. And when we say the photoelectron, that's the electron that is being emitted from the lower shell of the atom that the cathode electron is coming over to the anode for. Compton scattering is the predominant interaction. It degrades image quality. The interaction with outer shell electrons and results in random densities on the image, which is not something you're really looking for. Physical principles. Interaction depends on the photon energy and the effective atomic number of the tissue. So some anatomy requires constant media to differentiate contrast media, not constant. That's crazy. Some anatomy requires contrast media to differentiate between structures. In other words, it's going to be very hard to tell what's going on in somebody's intestine unless you have some contrast there to kind of show you where it is, particularly on an X-ray. So back in the 1950s, your kilovoltage units were the mainstay in treatment, running around 300 keV. As time progressed, you went into orthovoltage, supervoltage, megavoltage. And obviously today we're focusing more on the megavoltage. It's going to be very hard to find a clinic, not impossible, even in the States, perhaps, but most machines, I think, have progressed down to, at least having something around 4 MeV or greater. Imaging pathology, the pathology may affect the body's absorption characteristics. So you've got additive pathology. In other words, things that are adding to whatever's already around. You've got edema, you've got Paget's disease, you've got atelectasis, abscesses, pleural effusions. Those are always fun. And you've got destructive pathology, which lowers the body's normal attenuation ability. You've got astrocytomas. You've got necrotic areas. Those are something that's very interesting. If you actually take a look at a lung patient that has a huge tumor in there, but the middle of it has been hollowed out. Basically what you see is a ring of cancer there with just, nothing in the middle, almost looks like air. It's really kind of weird to see. You've got osteolytic metastatic disease and multiple myelomas. All right, so the fundamentals of imaging. You've got image density. You've got the degree of darkening on the image. You've got low image density, represents structures of high physical density. Image density increases as more photons reach the image receptor or film, and it's affected by the mass, the KVP, distance, grid ratio, most of all your KVP. And it's typically modified by changes in your mass. So the distance, you've got the gap between the focal spot and the image receptor. It is affected by the inverse square law. In other words, if the distance is changed by a factor of 2, the beam intensity must change by a factor of 4 in order to maintain that. It's also known as target to image receptor distance, focal film distance, or source to image receptor distance, or SID. This is something that you will see, physicists will generally work with when it comes to onboard imaging, EPID systems, things of that sort, in order to be able to run QAs. I've seen that in the clinic. You've also got contrast. So you've got the visible result of differential absorption rates by various body structures. It's modified by the KVP. It's affected by field size and the grid ratio. Contrast, always a lovely thing. It's the visible result of differential absorption rates by body structures modified by the KVP, and it's affected by the grid size, or the field size and the grid ratio. So you got yourself a picture here. This is, assuming this is on film. You can see all of the thoracic structures identified here: rib, scapula, vascular hilum, posterior rib, right atrium, liver, all of these things. And so you can see the less dense areas in the body here. You don't have a lot shooting through to, or you have a lot of dark areas here in order to show that off. But the rest of these, you've got a lot of tissue here that's going to start attenuating the beam as it passes through. Any guesses as to what that is? That is something that should not be there, and that is a very bad thing. That is a nodule that should be inspected, potentially cancer. All right, so how do we record all of this once we've got this stuff shooting through somebody? Well, we can use film. Back in the 2000s, I had worked at a few clinics which were still using film in order to be able to get positioning for a patient. It's not the fastest process, but you can make sure that the patient's situated where they need to be. Nowadays, you're looking more at something like digital imaging and IGRT, much faster, and you can make adjustments far more quickly than you can with the film. With conventional film, it's kind of like photographic film. It's sensitive to both light and radiation, which essentially the same thing here. It's different in spectral sensitivity. You've got 3 components. You've got the base, it supports the emulsion, dyed blue for visibility. You've got the emulsion, imaging forming component composed of gelatin and photosensitive silver halide crystals. And then you've got a protective coating, which protects emulsion from scratches, abrasions, skin oils, that kind of thing. You've got your latent image formation, and it's the image on the X-ray film that is not visible until the film is processed. It becomes the manifest image after processing, and it's determined by interactions between the emulsion and the remnant X-rays. So what are the characteristics here? You've got speed, contrast, and latitude. So for the speed, you have evaluated through sensitiometry. It defines a relationship between the exposure and the density. may be visualized on a sensitiometric curve, and film requiring less exposure for a given density is said to be higher speed. Density is measured by the densiometer. Contrast and latitude. Films may be designed for different contrast needs. High contrast films provide higher contrast, but require more precise technical factors, or low latitude. Low contrast films provide lower contrast and require less precise technical factors, or have a high latitude for such things. And you see more images there. See contrast coming down esophagus there. Storage and handling. Radiographic film is sensitive to light, radiation, heat, and humidity. Anytime they are storing radiographic film, you want to put it away in a dark place. Shelf life also affects the film quality. The longer it sits there, the less filmy it acts. Intensifying screens. It produces light in response to X-ray exposure. Visible light from intensifying screens accounts for approximately 99% of latent image. And the purpose is to minimize required X-ray exposure. So the screens in radiation therapy, you've got 4 distinct layers. You've got the intensifying layer, you've got lead, and you've got copper. And you can see the film here. You've got the protective coating, you've got the phosphor, reflective layer, and then you've got the base. So this is identical to normal radiographic screens, and the purpose is used on conventional simulators. Lead and copper screens are used for high energy portal imaging. You've got it about 0.1 to 0.5 millimeters for lead and up to 3 millimeters for copper. They eject electrons onto film or the imaging receptor and are used only in the megavoltage range. You've got a photostimulatable plate. Let's try saying that 5 times fast. You've got special detectors that convert X-rays into digital images. So you got a layer of phosphor material that stores the latent image. You've got helium neon lasers convert the stored electron energy to light. You've got emitted light energy, and that's collected by a special photomultiplier tube, which is converted to an electrical signal, which is then digitized and stored on a computer. Don't worry, I'm not going to ask you that on an exam. And the advantages are reusable high latitude post-processing image manipulation. In other words, we're trying to get things that are going a little faster here. Flat panel detectors are used amorphous silicon and solid state integrated circuits to digitize incoming X-ray signals. Similar to technology in laptops and other devices, the latent image stored in the thin film transistor array and converted to electrical signal. For film processing, you've got reducing agents that transform the silver halide crystals into black metallic silver. You've got the fixer, which removes unexposed silver halide from the film and permanently fixes remaining silver onto the film. And you got a water bath that's cleaning the remaining material or chemicals, and automatic processing is a chain of roller systems submerges the film into 3 tanks of chemicals and water and eliminates the need for manual processing. Darkroom chemical sensitivity is named after radiographer Marjorie Gordon. The darkroom disease, it's caused by glutaraldehyde. There we go. Sulfur dioxide and solvent sensitivity. Considered a form of multiple chemical sensitivities. You've got irritation, and then initiation, then you've got the triggering. You've got geographic or geometric factors here, magnification and distortion. Magnification, it's an inaccurate representation of the object size. And X-rays diverge. And the geometric arrangement of the X-ray tube, the patient, and the image receptor. And it's expressed as a factor so that we can get to it. So we know what that magnification is. So the magnification factor is the image size to object size, target to image and target to object. And we can either reduce the object to image distance or maximize target to object distance. We also have distortion. A change in the size, shape, or appearance of the structures being examined it occurs when the object plane or part examined is not parallel with the image plane. In other words, you're holding one at an angle as opposed to just being completely parallel. It's uneven magnification of structure, and you've got some angulation. So the distance is going to be a little off. Controlling the scatter, you've got beam collimation, shuttering. It prevents unneeded photons from interacting in the patient. You've got grid usage, which removes the off-angle photons. And then you've got the KVP, which lowers energy, lower energy minimizes scatter production. Now, a lot of that is film. Now we're going to start moving a little bit more into the more advanced areas of medical imaging. So for digital imaging, we've got an analog signal that's going to be converted to a digital signal. And the imaging information is raised in 2D pixels with a matrix. These are your common sizes. If you're looking at it in three dimensions, the representation is going to be known as voxels, voxels for volume. So for CT scanning, this is more of what you're going to see in today's clinic. You use it for simulating, which obviously is then going to be used for treatment planning. And you can couple that with PET in order to evaluate the tumor. The imaging basics, you've got a rotating beam that's measured by an array of detectors. You've got projections containing attenuation values, and they're reconstructed into a composite image. The final image are generally cross sections of the body, and after scanning and processing, the image window and width and window level may be changed to adjust image contrast and density. These are supposed to be separated, but apparently the advantages cancel out the disadvantages. Let's just show you some examples here. This is an example of a CT image. You've got one particular slice here where you can see something that's going on here. Could be cancer, could be something else. Generally, in my line of work, whenever I see something like this, I assume cancer just simply because by the time it gets to me, that's what they've pretty much classified something like that to be. Now, it could be other things. These are other things that you can see. This is not looking good. Got something else here. You've got here where you've got certain spots in the liver, which may need attention. I mean, you've got several spots here in this liver. I don't know if it's cirrhosis or not. When you get spine, you've got the aorta, you've got the spleen. You may have something going on here inside the head, and a CT can bring out some definition of whatever that is. This is some of the drawbacks that you do have with CTs. It's not enough to prevent you from using it, but when you have certain things that have a high, what seems to be a metal value or something akin to that, you can get scatter off of the sides here. And so you don't actually have an absence of material over here. It's just that the CT unit, when producing these images, interacts so heavily with this that the scatter off of this clouds what's over here on the side. And so generally on these types of things, you have to go through and you have to fill in the densities in order to get at this. I don't know if that's a biopsy needle or what, but you got something going on there. Nowadays, for patients, you have things like cone beam CTs, IGRT, where you have something going on here in the head of the gantry where you have a cone beam CT. You have solid state detectors down here in the EPID system, which if you want to know a little bit more about EPID and the electronic portal imaging device, it basically has a number of things in here that allow you to be able to reconstruct signals that you get from here. And this is going to be the onboard imaging that allows you to be able to position the patient. So you've got an MV beam here, which can come through and interact with the EPID system. And then you've got the cone beam stuff, which is over here off to the side. So you got your detector here, and then you've got your KV stuff going on here. And you can go through and you can position to see, you can see the different types of images that you would get using an MV beam as opposed to a KV beam. With IGRT, you've got image guided radiation therapy where you can line up the patient, you can image them in order to make sure that the patient has not moved or that the tumor has not changed. And that's the same kind of thing going on here. This, I believe, is Exio. That's the planning system here. Or could be, well, no, I believe that is a Pinnacle. Sorry, my bad. I believe that's Pinnacle. I recognize the block shape here. This is Eclipse. Both of these planning systems will give you different types of images and different ways of, well, not different types of images, but they will give you different ways of being able to see what dose is going into a particular part of the patient. So here we're treating a lung tumor, and boy, that's a big one. And here it looks like we're treating a prostate. But by using the CBCT, you can make sure that you are lined up in this particular spot. You even have systems now that see that if this is changed, they're able to change the plan on the fly, depending on what the results are, which is kind of neat. MRIs. MRIs are basically an external magnetic field used to align the natural magnetic poles of the human body's abundant hydrogen atoms. And trust me, you got a lot of them. Pulses of radio frequencies are applied to the patient, and then the return signal, after the pulses are applied, the return signals of how those hydrogen atoms de-align are collected, measured, and reconstructed into an image. So you got three elements here. You've got the intensity of the return signal, you've got the longitudinal relaxation time, T1, and you've got the transverse relaxation time, or T2. A lot of times when images are referred to by physicians, they want these merged with the CTs that are taken. They'll refer to them as T1 or T2. And there are other descriptions that you can use in order to be able to get those images or to refer to those images. They can be displayed in the transverse, sagittal, or coronal planes. Again, there are certain advantages and disadvantages of each. Wish the slide there had separated that out. You have generally in the head is a place where you use MRIs quite a bit. So you're going to take this and you're going to be able to identify certain anatomical structures. And you can see the big old brain goober right there. That's it could be edema. It could be tumor. It all depends kind of on what it is, what sort of sequence it is, and knowing how they respond. You'll also see MRIs in the spine. And this is showing a spot here, some pretty solid destruction here of a vertebral body. Same thing over here. That guy's got something going on there. Not sure what it is. You can see breast tissue here where you can see that particular malignancy. Nuclear imaging. You've got images of physiology and metabolism and biochemistry rather than just the anatomy. You've got selective uptake of different radioactive compounds that are used by different organs in the body. And it uses special equipment. The radioactive substances can be traced in the body to see where and when they concentrate. So SPECT, you create three-dimensional images of internal organs that receive both anatomy, that reveal both anatomy and function, and can detect the presence of a tumor. So you may have something going on. It's used quite a bit in head and necks. Bone scans. It's a cornerstone to skeletal. Let's try that again. Cornerstone of skeletal nuclear imaging. There we go. Provides physiologic information depicting blood flow to the bones, bone metabolism, or turnover. There's a high sensitivity here and sort of lacks specificity. There we go. So you can kind of compare as you go through and kind of look for things that are out of the norm. I don't usually use bone scans that much, so I don't know a lot about them. But generally, you don't have dark spots like these things lighting up there, which may lead you to think that there's something going on at the rib. Nuclear medicine, or PET, images physiology, metabolism, and biochemistry rather than the anatomic structure. So basically, you've got a gamma emitting nuclide that's attached to a synthetic energy molecule. You know, usually it's the fluorine 18, the fluorodeoxyglucose, FDG. So you put that into the body. I've had one of those done on me. It's not a lot of fun, but you get a lot of information out of it you wouldn't ordinarily get. The nuclides collect all at sites of high metabolic activity, such as malignant cells, the ones that you're interested in nuking. The gamma radiation is collected and transformed into a 3D mapping of accumulation, distribution, and excretion activity. In other words, where is it accumulating? Where is it going? And where is it coming out? You combine that information with a CT. So you got a CT image here, you got a PET, which is a lot of what I can do during the day. And you can match up the physiology with the anatomy. And when you do that, then you can figure out how to plan in order to treat somebody. Oh, this person's got a lot going on. I mean, you can see stuff going on in the neck. Obviously, you got the heart over here, but you've got axillary nodes, it looks like, things going on over here in the lung, whatnot. That's not a good story. Ultrasound, also known as sonography. And basically, you have a transducer that is used to generate a mechanical disturbance or pressure or sound wave that moves through the tissue. As the sound wave moves through the body, it encounters a variety of tissue densities and interfaces that reflect and refract or change the direction of the ultrasound energy. And this reflected energy is collected, measured, and transformed into a composite image. And trust me, if you learn how to read one of those things, you are doing better than I am, because I've seen those before. I don't think I'm very good at it, but that is a skill. That is a skill that is learned. And it's useful for delineating minor tissue changes. It's also useful, this is why they use it for pregnant women, because you don't want ionizing radiation interacting with a lot of tissue in a fetus that's going to change very rapidly. You've got a lot of cell production going on there and reproduction, and ionizing radiation is really going to play with that. And so this is why ultrasound, which does not have ionizing radiation interacting with that, is used. And it can also be used in other areas as well. They've actually used something called a BAT system for localizing prostates. That was done until you had onboard imaging going on. Like here, you've got the prostate and you got the bladder. You can see that kind of thing going on. It was a very, fairly cheap system. So when you didn't have the onboard imaging, I can understand why you would have that. Still, it was just very hard for me to read. Mammography, conventional, digital, or 3D. It uses X-rays to look for tumors or suspicious areas in breast tissue. And this is one of the things that you use in order to be able to determine if there's anything there that is awry. So you can see something there that might be suspicious, something there. Virtual colonoscopy. It uses X-rays and computers to produce 2- and 3-dimensional images of the colon, used to diagnose colon and bowel disease, including polyps, diverticulosis, and cancer. The advantages are more comfortable than conventional colonoscopy. I wouldn't know because I've had a conventional colonoscopy. Not exactly sure how this would differ from that, but apparently no sedation is needed, and clearer, more detailed images, and takes less time. The unfortunate thing is that you can't take tissue samples. The polyp smaller than 10 millimeters in diameter may not show up on the images. So this is an example of what these polyps look like. You don't want to let those go. Get them removed if you find those kinds of things. Trust me on this one, developing colorectal cancer at 36 is not a fun thing. So make sure you get the proper screening when you can. Sentinel node mapping. So only the sentinel node, the first lymph node to which cancer is likely to spread, given the disease and where it's positioned, is removed rather than all of the lymph nodes. In other words, it's kind of like the link in a chain. If you take out one of them, then maybe you can spare the rest. So you inject either a blue dye or a relatively non-toxic radioactive substance and see which lymph node it reaches first. And that lymph node is the sentinel node and is surgically removed. You have less recoup time, more accurate assessment of the spread of the tumor, and decreases risk of long-term complications and side effects. Apparently, it's not available for everyone. I'm not quite sure why that is. But you can see the images here. You've got axilla, you've got a node that's popping up right there. So you've got a primary site injected with a radioactive tracer. You're wanting to find out where stuff from this ends up. So you've got a lymph vessel here carrying it to the sentinel lymph node. Take that guy out, and maybe you can help stop the spread. So I hope some of this was useful to you in sort of seeing how imaging plays a role in not only diagnosing disease, but a little bit with radiation therapy.